Welcome and celebrate the release of Dr. Raza's second book, The First Cell, and to honor our guest, Dr. Raza. It's such a pleasure to be here with you. I'm sorry, I'm going to be a little formal in the beginning. I feel like a lot of you know her as my aunt, but I need to talk about her as an academician for a brief few seconds so that you can understand better where this book is coming from and what it means to her and to all of us. So for those of you who don't know, I refer to Dr. Raza as Achi. And all my life that I've known Achi, she's been a very strong academician and a clinical researcher. Since her time as a young fellow at Roswell Park in Buffalo, she developed a keen interest in myeloid malignancies. And it was after a harrowing experience with a patient whom she became very close to, who's also mentioned in The First Cell, JC, that she decided to study the precursor state of acute myeloid leukemia that we call myelodysplastic syndrome, or MDS, and make that her career thing. She wanted to do justice to JC by helping find a cure for AML or MDS. Dr. Raza, throughout her career, has held some very, very impressive positions in the world of academia. She's actually someone who earned a full professorship at the age of 39. I'm already older than that and nowhere near, as are most of us in this room. And that wasn't it. After becoming a full professor in Chicago at Rush, she became the director of the myeloid disease program, and then went on to Worcester, Massachusetts, where she became the director of MDS at UMass. This was followed by another directorship role at St. Vincent's in New York City, and then finally at her current place in Columbia, where she is recognized as the, what is the Chinese name? Sorry.
It's okay.
No, it's Chan Shun, Achi, I'm so
Soon
sorry.
Xiong, it's okay.
Chan Soon Xiong, professor of medicine, and she heads the MDS program at Columbia. But just a little bit of a personal introduction now. Honestly, to this day, I am an Achi wannabe. Ever since I was 5 years old, and my sister can vouch for this, ever since I was 5 years old, my favorite bedtime story was to listen to my dad tell me how Achi was this awesome doctor who would wake up in the middle of the night and go visit patients in the hospital. And I would routinely ask her, will I one day be like Achi? And he would say, of course you're going to be like Achi. And I also shamelessly admit that I was just telling Nina, when I was a teenager, I grew my hair to match Achi's long mane. Of course, none of you can envision her with that, but she had very long hair all the way up to her hip, and I just wanted to look like her. She was everything in my mind that I wanted to be. One might wonder, am I an oncologist today because of her? Absolutely. When I started my internship and when my first rotation incidentally was the hem-onc floors, I absolutely fell in love with them, thinking that, you know, this is what I want to do because it'll make me closer to being more like Achi. But somewhere after that, I realized that it's not easy to be like Achi, that it's not everyone's thing. She's just one of these very, very special, rare, and brilliant people. And now I just silently admire her and just am so in awe of all that she achieves every single day. And her book is one such latest achievement. So I'm sure I've said these things to you before, but you're just everything that I've always wanted to be. So thank you.
Thank you, Zehra.
So before I go on talking more, I want to bring back the attention to the first cell. And since it's a very new book, it was released just in October, I would like to tell you, for those of you who have not read it, if I were to describe it in one sentence, it would mean that we have wasted millions of dollars doing cancer research, and we are really not much ahead of what we used to do 50 years ago. And she exemplifies this as the 7+3 regimen that we use to treat leukemia. It was done 50 years ago, and we're still using that very regimen in the same order to cure acute leukemia. So where is all this going? Like, what are we doing in the cancer world? What is all this great talk about cancer research? So, Achi, to me, I've always recognized you as a researcher and such an avid proponent of clinical trials. And your book is not, it opens one's eyes to the futility of clinical trials, that FDA approves drugs for just 2.5 month survival benefits, and you question them. That just comes as a sort of a shocker to me, because you know, I've seen you as being the proponent for Revlimid or Vidasa. What do you have to say about that? Or in other words, what do you think, what prompted you to write the first cell?
Thank you, Zehra. Let me begin by saying I'm deeply honored and flattered by everything you said. And thank you to Hussein. Where is he? Thank you very much, Hussein. I'm delighted. My other niece, Sakina, is here also. Thank you for coming, Sakki. And thanks to all of you for taking the time this evening to come. I think that there are many oncologists in this room. Today, cancer is not something that happens to other people. If you don't have cancer yourself, you probably know someone who does, or you have lost someone that you loved to cancer. So it's something that's very close to all our hearts. The statistics look very grim, that going forward, 1 in 2 men and 1 in 3 women will get cancer. Given all of this, the question Zehra asked, why did I write this book? The reason the one reason, if I'm going to summarize it, is to bring the patient back front and center into every discussion from now on. Because I do feel that as oncologists, what we have done is we have become obsessed with wanting to cure the disease, but we neglect the illness. Now remember, disease is something that doctors diagnose and treat. Illness is what patients experience. And what is the primary rule of medicine? So many doctors in the room, first do no harm. Exactly, everyone can repeat this rule. First do no harm. So in that light, think about what Zehra just said. If we do a clinical trial which produces 20 to 30% response rate, we proclaim victory from the rooftops. For a 2.5 month improvement in survival, we call it as a game changer. So that means 70 to 80% patients experienced no benefit at all. In fact, they were hurt because they experienced all the toxicity but no benefit. Secondly, 42% cancer patients today, 42%, become completely financially ruined by 2+ years of their diagnosis. 42% patients in this country, which is so affluent, it is obscene. Why are they becoming financially ruined? Because every drug costs $100,000 a year. And to benefit 20 to 30% patients for a few months, we treat 100 patients, make 42% of them completely lose every penny of their life savings. And the 30% we are benefiting, what exactly are we doing for them? So I'll give one more statistic and then turn to Zehra for her second question, because the reason I wrote this book is, why are we always congratulating ourselves for the few successes, and why aren't we thinking about all the majority that we are hurting? That's number one. The main reason for me, bring the patient back front and center. Think about what we are doing. Second statistic I want to give. Today, we are curing 68% patients who are diagnosed with cancer. That's fantastic news, 68%. What are we curing them with? Slash, poison, burn. The same thing we were using 50 years ago. Why? It is a horrible treatment. Chemotherapy is terrible. Why in this day and age are we still using it? What happened to hundreds of billions of dollars spent in research to try and find new drugs? Where are they? So we can be proud we have cured 68%. The 32% who present with advanced disease, their outlook is the same that it was 50 years ago. Alex Trebek, Jeopardy host, diagnosed with stage 4 pancreatic cancer. How is his prognosis different than it was 50 years ago? Not even by a day. So what are we doing? But he's going to get first line of therapy, second line of therapy, third line of therapy, then die anyway and be tortured. He won't be financially ruined, but everyone else like him will be. Last thing, do you know that of the clinical trials that are being done today in America in cancer, think of this statistic seriously, guys. Of the clinical trials, experimental drugs brought to the bedside, 95% fail. 95% today fail. The 5% that succeed add a few months of life. Yet, just in September issue of Stat, this is what the statistic is, this whole thing is so shocking. Dr. Richard Pazder, who is now heading the Center for Oncology Excellence at the FDA, very famous name, any oncologist knows Richard Pazder. He quoted that recently 3 large, well-controlled experimental trials were done using checkpoint inhibitors, PD-L1 inhibitors, in multiple myeloma. 3 large trials, they all failed. So first of all, why did we need 3 large trials? And those have failed, but do you know how many other trials are going on right now in the country directed at drugs which are the Me Too drugs? Because 1 checkpoint inhibitor or 2 got approved, everybody wants to make a biosimilar, get it approved so they can make their billion. So these 3 trials failed, but do you know how many trials he said are going on in the country right now? Think of a number, 50, 100, 500, 1,000, 1,500, 2,000. 2,200 clinical trials are going on right now for checkpoint inhibitors alone. Things that have failed. And each of these will have a 95% chance of failure. Yet, $150 to $300 million are being spent on each trial. Why? Because if one of them succeeds, it's going to make billions and billions every year for the next 20 years for the company. So they are willing to do it for that reason. But the question Richard Pazder asked was a very good one. He said, are the patients the company's resource? And this is the question, these are the questions I'm asking, Zehra. Why is it that in this country, no one is thinking of these issues? Why are young oncologists being minted at Columbia and Cornell and Brown everywhere to go and develop a clinical trials program in pancreatic cancer, bring 10 clinical trials, each will give us 40,000 per patient. Why are young people being told to participate in this? So I think for all these reasons that somebody has to speak up. Now what incited me to do it finally now is another story, but I really think that the most important message of this book is to think about patients and think about what all of you are, or each of us is doing. I'm doing the same things. So it's criticism of me as well.
Yeah, I mean, we have no choice, right? Because
Yes.
that's what the guidelines are, and
Yes.
that's what we're required to do. I do want you to read a couple of passages from the book, but before doing that, you've quoted many beautiful poems throughout your script, and one of them is my favorite, the one by Emily Dickinson, where you talk about moments of sublime grace in periods of difficulty that patients experience. I would like you to read that poem for me, because I'm sure you read it with so much pain. It's this one, Achi.
Which one?
I had no
Oh,
time to.
yeah.
Yeah.
Okay. Thank you so much. Guys, I run 3 to 5 miles every day, and the one thing I do while I'm running is I commit poetry to memory. So this is a very beautiful poem. In fact, I have committed to memory dozens of Emily Dickinson. And the one Zehra asked me about is, I had no time to hate because the grave would hinder me. I had no time to hate because the grave would hinder me, and life was not so ample I could finish enmity. Nor had I time to love. I mean, think of what she's saying. I had no time to hate because the grave would hinder me, and life was not so ample I could finish enmity. Nor had I time to love. But since some industry must be, this little toil of love, I thought, was large enough for me.
Wow. Beautiful.
That's what we need, these little toils of love. And now that you said it, I'll recite one more from her.
Yeah.
So beautiful. It looks, Zehra, it feels like Emily Dickinson was speaking directly to me when she said it. I measure every grief I meet with analytic eyes. I wonder if it weighs like mine or has a different size. I wonder if they bore it long, or did it just begin? I cannot find the date of mine, it's been so long a pain. I wonder if it hurts to live, and if they have to try, and whether, could they choose between, they would not rather die. So Zehra mentioned a moment of grace. As oncologists, I see, as an oncologist, I see 30 to 40 patients a week. Most of them I'm walking to their deaths. But sometimes a personal experience can really shake you up. And my daughter's best friend since she was 15 years old, Andrew, at 22 years of age, this gorgeous, beautiful, young, gay boy, so fashionable, so lovely, so talented, so brilliant. And every vacation, as you know, Charles, Rebecca, Scheherazade, and Andrew, they were all over Europe, everywhere they went together. Suddenly feels,
right?
yes, of course, suddenly feels weakness in his arm, and within hours he's quadriplegic. He's diagnosed with a 9-centimeter glioblastoma, which they couldn't remove. So now, from the moment of discovery, you know that this boy has 0.00 chance. Do you know what he did as soon as the neurosurgeons closed him up? They couldn't remove the whole tumor. They closed him up. He came to his consciousness, and the first thing he said, he turned to his mother and he said, "Mom, don't worry, just call Azra. She's on the cutting edge, she's gonna cure me." How ashamed did I feel in that moment? How can I look at myself in the mirror anymore? How are we failing the Andrews of this world? And do you know the moment of grace that I wanted to mention about him? We could do nothing for him. No, not nothing. We tortured him with radiation, chemo, more surgery, immune therapy, more radiation, more chemo, so that the poor boy's whole mouth and esophagus and GI tract is one raw wound for the 16 months that he lives. He's 23 now. Scheherazade and his birthday are 1 week apart. He was 23. And they brought him this DNR form to sign, do not resuscitate. How do you ask a 23-year-old to sign a DNR? He refused. He said, take it away. I'm not signing it. They took it away. That evening, his father came to, this is just 3 weeks before he died. That evening, Zehra, his father came to spend the night with him. As soon as the father came, he asked for the form back, signed it, saying, I couldn't do it in front of my mother and my sister. They wouldn't be able to take it. This is a moment of grace. 23-year-old is dying, but he's thinking of his mother and his sister. He wants to protect them. This is the nobility of endurance. I'm saying all this, and I have written story after story after story in this book, not to revel in suffering and pain. No. But this is the only kind of empathy and shock to your senses that will be able to shake you up and make you rise out of the doldrums and this sort of complacency that we have drifted into, just giving drugs and treatments mindlessly to patients. Until and unless we become emotionally invested and look, you see, statistics just become statistics. 1 million people killed, 500,000 die of cancer every year. That's a statistic. But one Andrew, look at the granularity of his suffering. And that's when you realize that this is about humans and start to question, how many Andrews is it going to take is my question. How many Andrews before we? So what is the solution then?
Absolutely.
Can I say something?
No. Please, there'll be a moment for question answer. So, because if you break my thinking right now by interrupting, then it will just become a question answer thing, which we are going to come to.
I mean, this is just so, I mean, I've read the story, I've heard it from Sheher, but just hearing it from you again, and that's what makes me wonder, actually, you as a parent, watching your child go through something like this for a second time. Sheher lost her dad when she was very, very, very young, and no child should be without a father. And she remembers all of that, despite being a 4 or 5-year-old kid. She remembers Harvey's harrowing experience. Would it be too much if I asked you to read something from?
No, I will read it. I normally don't read about Harvey, but because Zehra, you were there the whole time. Harvey adored you, and you saw it all happening.
But he actually this is what I was telling him this morning. I never had any idea till I read the book how much he suffered, how much you suffered, because in front of all of us, he was just so graceful and doing his usual things, waking up at 3 in the morning, working, taking Cher to the zoo, taking us to the movies. I honestly had no idea.
Yeah, that's Harvey. I'll just read the first opening paragraphs of the book for you because you'll get a flavor of what I'm talking about. In the early spring of 1998, my husband, Harvey Preisler, was diagnosed with cancer. The following year, we planned to take our 5-year-old daughter Shehrzad and my brother Javed's 2 children, visiting from Pakistan, Musa and Batul, 8 and 12, to San Francisco for a highly anticipated vacation. Musa and Batul are younger siblings of Zehra and Sakina. We'd already postponed the trip twice before, but it could be delayed no longer. The children were eager, and given Harvey's disfiguring facial edema and the enlarging nodes, some form of aggressive treatment, sure to require us to stay put in the city for months, was now imminent. Before any of that happened, he felt strongly that the family needed to get out of the sweltering heat of Chicago for a vacation, even if just a week. Our flight to San Francisco was on a bright, clear summer morning. Having arrived at the gate a good 90 minutes before our departure, we split up. Harvey sat down in the boarding area while I chased the children around O'Hare. We got something to eat at the food court and then returned to the gate. I was shocked by what I saw. Harvey sat looking dazed as streams of sweat poured from his body, making little puddles under his elbows, on the armrests of the chair, and under his knees on the floor. He was beet red. Tributaries of glistening perspiration filled the lines in his handsome face, making it appear startlingly young. He looked at me with hushed anxiety. I sent Batul running for the nearest cafe to get me a handful of napkins. I dabbed Harvey's face and arms, wiping the chair and the floor. There was no respite. The sweat came in torrential waves. His t-shirt and shorts were entirely soaked and dripping. The children stood around, trying not to look, their faces ashen. It was a good 15 minutes before the deluge subsided. I walked to the gift shop, purchased a fresh pair of pants and a shirt. Without saying a word, little 8-year-old Musa stepped forward, quietly took the package from me, and gently escorted a bewildered Harvey to the restroom. Being oncologists, Harvey was head of the cancer center at the university. Being oncologists, both Harvey and I understood precisely what the sweating meant. Known as a B symptom, it's a well-recognized manifestation of many cancers, especially lymphomas, and it's not a good sign. B symptoms are associated with a more advanced, more aggressive disease with a poor prognosis. I suggested we cancel the trip and return home, but Harvey, not willing to disappoint the children yet again, insisted on going ahead. The first 24 hours in San Francisco were filled with apprehension as we drove the children around the crooked street and the harbor, not knowing what to expect, fearing the worst. Nothing happened. Harvey began to relax. Then in the middle of the third night, I woke up with a start. Water dripped steadily on my face. Harvey's arm was arched over my head, running like a faucet. This time, we not only had to change his clothing, we had to call housekeeping to replace the soaking wet sheets. By the time we returned to O'Hare a week later, Harvey developed another bizarre syndrome associated with many cancers. His left wrist suddenly blew up to twice its normal size. Despite the extra strength Tylenol, he was writhing in agony as we climbed into the car to go home. It took 24 hours of cold packs and heavy-duty analgesics to control the excruciating pain. The next few days were some of the most tormented. He experienced regular episodes of drenching sweats once or sometimes twice during the night, requiring fresh bed sheets and clothing changes. As swelling subsided in one joint, it popped up elsewhere without warning. Fresh lesions began with a tingling, burning sensation, becoming bright red and sizzling hot within hours. Nomadic lymphoma cells meandered autonomously, rudderless. Edema regressed from the face only to reappear in his joints. Lymph nodes in the neck and armpits swelled one day, receded the next, followed by sudden enlargement of the spleen. Itinerant cells segregated, dispersed, recollected, vanished, regrouped. They wandered the body with a studied carelessness, entering and leaving organs at will, disgruntled, edgy, exploring possible niches in various organs, rejecting some, settling in others. Horrified, helpless, we watched the drama unfold. Harvey from inside, I from the outside. The lymphoma marched on its aimless, monomaniacal journey into irresolution with a motiveless malignity. Cancer is what I had been treating for 2 decades, yet until I shared a bed with a cancer patient, I had no idea how unbearably painful a disease it could be. It was the summer of our discontent, cancer and its discontents.
Thank you so much for reading such an emotionally challenging passage. I'm going to change the pace a little bit because I think it's left a lot of us feeling very raw. We do have some brilliant young residents and fellows and young attendings in the room. What would you say is your message to them, given that they're being raised in this culture of promoting clinical trials?
Thank you, Zara. That's where we want to end this discussion and then open it to questions. So first of all, I want to say that this is not a doom and gloom book at all, okay? This is a very forward-looking, actually very optimistic book. But I had to tell, you see, I was going to tell the stories of all my patients, including Andrew, but then I realized how dishonest it would be if I didn't talk about myself and my own story. It has been 18 years since Harvey died. I haven't been able to voice or verbalize any of it until now. And what forced me to do it was that I felt really badly if I didn't do it, it would be so unfair to the other patients. And if I was going to do it, then I had to open my heart completely and just write everything that I was feeling and what Harvey went through, as some of us who are oncologists know what patients go through. But to describe all the pain, the reason is that it will liberate us from the past now. Let us make it the past, and looking forward, what should we do? So until now, the strategy of treating cancer is you try to kill every last cancer cell. In fact, we have developed some very sophisticated technology to identify minimal residual disease that is left behind after we are done with all the slash, poison, burn, to detect 1 or 2 cells in a billion cells. We go after every last cell, and that ends up killing most of the patients and making them financially ruined. I'm saying, why not go after the first cell and prevent it? So do you know that death from cancer, first let me say this, death from cardiovascular disease has gone down by 70%. 70%. Heart attacks down, mortality low. Death from cancer, 1% a year. But 1% a year means in the last 2 decades, let's say, we have come down by 20%. That 20% reduction in mortality is not because we developed some wonderful new treatment. The reason is anti-smoking campaign and the screening measures, mammography, colonoscopy, PSA and pap smears finally began to show an effect. And that's it. No new treatment. It's early detection and use of existing drugs more intelligently. With experience, we learned this combination is better than that, so survival improves. But the same old chemotherapy. So what should young people be doing in the future, and how can we shift the paradigm literally very fast? Very simple. Instead of chasing the last cell, let's try to detect as early as possible the first cell. No, not even the first cell. Let's detect the footprints of cancer before it becomes cancer and prevent it from becoming cancer. How can we do that? It's not that difficult. We already have techniques to detect minimal residual disease. We can detect minimal initial disease. Now everyone asks me, oh, mammograms can detect cancers which wouldn't have killed for 30 years, or colonoscopy, or there are problems with PSA, we are diagnosing cancer, over-treating, over-diagnosing. Yes, those are ancient techniques, for God's sake. Those techniques belong in the Stone Age, putting a tube into someone's gut and looking. No, this is the day and age of cutting and pasting DNA. The technology of CRISPR and all the latest fancy genomics, proteomics, transcriptomics, metabolomics, all these things we have developed, that's what we need to be using. So my idea is very straightforward. We need to detect cancer early. We shouldn't be using the old techniques to detect cancer early. We need to develop the latest possible technology, whether it's implantable devices, scanning techniques, imaging devices, or studies of biomarkers. We need to apply all of these things to find cancer early. Now, remember, the last cancer cell we look for in patients who already have cancer we have treated. Who should we be looking for the first cancer cell? Why would anyone want to look in 22-year-old Andrew for the presence of cancer? You know why? Because no age is immune from cancer. So what I propose is that from birth, we have to start monitoring constantly for the appearance of the first cell. Not just cancer, I'm making a prediction here today. All of healthcare in the next couple of decades will go toward prevention rather than active treatment. Preventing Alzheimer's. What diseases have we cured? Strokes? Diabetes? What have we really cured except infectious diseases? Nothing. Everything needs to be prevented. In fact, heart disease, the mortality went down 70% only because cardiologists are smarter than us. They prevent a heart attack from happening. So, having advanced cancer is like having a heart so badly damaged by an MI that the only treatment is a cardiac transplant. Well, for God's sake, we can do better. Just follow what the cardiologists are doing. So, for example, I'll give you an example of what I'm doing. With the biomedical engineers at Columbia, I should have brought that chip. We have developed an M chip. Sam Sia is one of the top names in the country in microfluidics. The microfluidics that proved to be the end of Elizabeth Holmes, the Theranos woman. She got sued for that. The company went bankrupt and all. Well, microfluidics is the technique that we used in this M chip. This M chip is FDA approved. All men have to do is prick their finger, 1 drop of blood onto the chip, and it measures your PSA, and it can be read in a tiny little device that you have. So at home, you can now check your own PSA level and monitor yourselves constantly, every week if you want. I'm saying stop using ancient technology once a year looking for cancer. That's too old. What we need to do is latest technology and treat the human body as a machine which should be constantly monitored. So I'll give you some examples besides the M chip that's already FDA approved from Columbia, that was licensed off to this company called OPCO. But imagine this, you go to sleep at night and your bed sheets scan you for the presence of the first cell. You stand in the shower and your shower images you. You sit on a fit loo which takes part of your urine and analyzes it for the detection of biomarkers associated with renal cancer, and with you brush your teeth and your saliva is taken off through your toothbrush. Think of this. Women wear a smart bra just for 2 hours every week. Just for 2 hours every week. This smart bra is fitted with 200 microsensors to detect changes in temperature. So basically, it's thousands of times more sensitive than a mammogram, and it doesn't require all those horrible things once a year and all that money, just a smart bra. You know that when a cancer cell forms and starts to divide, it divides faster than normal cells. So it needs more nutrition. To get itself more nutrition, it starts making new blood vessels. As soon as that happens, the area becomes hot. That's what we pick up with ultrasounds, with sonograms, with scanning devices. You can pick a hot area. So let's say tonight I go to sleep in my sheets that are detecting this hot area in the head of my pancreas. It doesn't mean I should wake up tomorrow morning and have the Whipple procedure done on me to take out the pancreas. Of course not. The next thing to do is that I should be monitored carefully. Now there is a region of interest that can be examined very carefully. Next thing we need to do then, why do we have to rely on any one test as the ultimate and end of it all? No. Now I have a suspicion, why don't we do liquid biopsies, whether it's from tears or saliva or blood or urine or sweat, whatever it is. There are biomarkers that are associated with pancreatic cancer that we should be able to detect. Once we have 20 tests pointing to the same thing and repeated imaging or just the bed sheets show that the thing is growing, then you have more of a confidence that, okay, now I should do something about it because it's growing. Then imagine trying to kill just a few million cells compared to a metastatic stage 4 pancreatic cancer. Nothing works at that stage. But at this small stage, you can zap it with a laser. You don't even need radiation that's going to produce so much toxicity. So when you ask me what should young people be doing? First of all, young people need to know that no individual can give the answer. It has to be a group effort. We need to involve oncologists, basic scientists, molecular biologists, computer experts, IT guys, artificial intelligence people, nanotechnology, imaging people. You know, everybody has to work for the same goal. And this is a capitalist society, Zehra. So the very good thing in a capitalist society is competition. Just think of one statistic. It took us 15 years and $2.7 billion to sequence the first genome. 15 years. Today it takes 3 weeks. 15 years down to 3 weeks within 20 years. Instead of $2.7 billion, $2,000. This is the beauty of capitalist society. So if we just set a new goal and say, all young people, all pharma industry, everybody wanting to make money, right now you are investing in clinical trials that have a 95% chance of failure. Why don't you go for something that's going to be more fruitful for you? Go and try to develop technology for the first cell. And so somebody asked me, Dr. Raza, don't you think pharmaceutical industry will be mad at you because you're taking away all their business? I said, no, right now only 1.7 million new cases of cancer occur every year. Those are their subjects. But suddenly if you have to monitor every healthy individual in the country, that's 300 plus million people who will become their clients suddenly. So what am I proposing? And in the book, and of course this is not new, as Zehra said, I began by studying and treating acute myeloid leukemia. By 1984 it was clear to me that in my lifetime this disease is so complex, it's such a monstrosity that in my lifetime it will not be cured. And I was right, because look, sadly, because as Zehra said, we are still using the same 2 drugs I was using in 1977. In 2019, still the same 7 and 3. So in 1984, I said, well, the only solution is detect it early, even the acute leukemia, and intercept. Don't let it become acute leukemia. That's why I started studying pre-leukemia. Iole came and spent time in my lab. When was that? 1997. Iole came and spent a year with me, and we have been studying consistently with a focus. And the most important thing I did is that it helped me to be an immigrant. Because once I decided that I'm going to start studying pre-leukemia, follow these patients as they develop leukemia, and then try to study them longitudinally. If I had gone to school in this country, I would have immediately gone to make a mouse model for it. But luckily, I was a naive chit of a brown female who had landed from Pakistan, didn't know any better. I said, well, if I'm going to study the disease, let me save the cells on my patients. I started banking them in 1984. Today, I have the largest tissue repository in the world with over 60,000 samples from thousands of patients. To this day, I do 5 to 10 bone marrows every week in my clinic with my own hands. I know how much pain I'm giving patients. No one refuses me. Dr. Raza, even if it doesn't help me, take my bone marrow and my blood, it will help someone else. There is not a single cell in this tissue repository of 60,000 samples that comes from another physician even. Every single vial has a story for me. Every single test that I plan on these, every time I go into the tissue repository and pull out 300, 400 samples, we end up in very important observations in papers in Nature and Science and Cell and New England Journal of Medicine. Just look at our publications for the last 5 years. There is no high profile journal where we haven't published. But so what? Should I be congratulating myself on that? That is not the end all. To publish papers in Nature and New England Journal of Medicine, I feel like shooting myself. When I can't provide an answer for poor Andrew, why am I celebrating a paper in Nature? For what? So what do we have to do then? Well, the answer is right there. We need to study these samples as an entire tissue repository. Thousands and thousands of patient samples at multiple time points as they progressed in their disease. Just to give you an example, to study 200 patients using 4 techniques: genomics, transcriptomics, proteomics, and metabolomics. Just 200 patients at 2 time points, pre-leukemia and leukemia. You know how much it costs? $4 million for 200 patients. So if I want to do, let's say 2,000, I need $100 million. Who's going to give it to me? You know that the government doesn't even support the maintenance of the tissue repository. It costs me $1 million a year just to keep the samples and keep adding to them. $1 million a year. How do I raise them? You know who supports the tissue repository? The patients. They all want to give me money. I said, no, I don't need personal money. Give it to my tissue repository research support. Or I hold fundraisers. The first fundraiser I held was at the home of Hugh Jackman, as you know. He's a good friend who always is so supportive. This year when I had the fundraiser, Hugh Jackman never does this. At Lincoln Center, he sang and danced for me. And you know what he said? Azra, we are with you. I love the way he takes my name, Azra. No, so these are the people who are supporting. Paul Simon, James Taylor, Wynton Marsalis, Diana Reeves, everybody gives their time for free for the tissue repository and for this research. But to raise $100 billion that's my next deal, and my biggest aim is to make this book, even though it came out 2 weeks ago, obsolete. Because the real project is so much more important than the book, guys. The real project is the patient. We have to help the patients. So I can raise $100 million, either go groveling and begging in front of some billionaire, or the people who can help me are the people who are at the highest risk of getting cancer, because they should be most interested in finding the first cell. Do you know who those people are? Do you know who is at highest risk of getting cancer? It's people who have had one cancer. 1 in 5 new cancers appear in someone who already had a cancer. Harvey at 34 was diagnosed with his first cancer, testicular teratoma. And at 57, he got his second cancer. So people who are at highest risk are cancer survivors. In this country today, there are 20 million cancer survivors. My appeal is, if just 1 million of them give $10 a month for 1 year. That's it. $10 a month for 1 year. If 1 million people give it, I have $100 million, I can study all those samples in the tissue repository. Towards what end? The idea is acute leukemia, trace it back to pre-leukemia. Then ask the question, why did these individuals even get pre-leukemia? Who are these healthy people who got it? So I have saved everyone's germline DNA, normal control, buccal smears and T cells from everybody. So now we look at their normal DNA. You know that the mutations in genes like BRCA, BRCA1, and this is associated with women having ovarian or breast cancer, right? Every cancer will have some genetic component. Who are the people who got pre-leukemia with chromosome 5 abnormality? I have thousands of those patients. Look at their germline DNA. Maybe they were born with a polymorphism or a mutation in something which suddenly will appear when you study thousands of people's germline DNA who all got pre-leukemia. And then we can start doing the same thing for every cancer and identify who is at risk for pancreatic cancer, who's at risk for breast cancer, who's at risk for pre-leukemia. Develop a barcode of these proteins or these biomarkers, put them in a chip and implant the chip as soon as a baby is born. This is where we are going in the future, guys. This is not, and as I said, I wish I had brought the chip because we have the prototype. It's all going, it's very exciting. I've described it all in the book, but again, through the prism of human anguish. Because the subtitle of the book is to me as important as the title. The first cell and the human costs of pursuing cancer to the last. Let us not forget that human cost. Thank you.
Thanks, Akshay. That's beautiful.
He has to start.
Right. Absolutely.
I yelled at him already. But you see, if I get interrupted, then my whole flow goes. So let's.
Saeed,
Dr.
absolutely.
Akhtar is going to make a comment.
I beg to disagree with you a little bit. I think we should do both. If somebody
Yes.
develops a cancer, we have
Yeah,
to
we
treat
should
them.
both. Yeah, no, absolutely. I didn't say it, but right now, but you are absolutely right, and it is there in the book the whole time.
So and I think the best audience for you will be the reason we haven't made it, in my personal opinion, because the system is very crooked and corrupted. And we've basically given the research, cancer research to pharmaceutical industry. And they're making a lot of money out of it. And so the common sense literally has gone out of the picture.
No, you're completely wrong. Please let me tell you. They don't do any research. They only develop drugs.
That's right.
All the research, so this is where the crookedness comes in. That all the research is supported by NIH to investigators like me in academic institutions. But let's say I find a target. Now to take this target and develop a drug and take it for a clinical trial, they don't support it because that clinical trial will cost $300 million. And that the government doesn't have. So I have to hand over whatever I have discovered now to a pharma company. So who is crooked? Pharma companies from day one are saying we are here to make money. They are not giving you any illusion that they are here to serve humanity. But the NIH is supposed to be serving humanity. Why are they supporting this system?
That's because we have given them the
Yes.
green light to do all the trials because they have the money to do
Yes.
that. Because once they develop a drug, they say, oh, take it for life.
Yes,
Ibrutinib, you take it for life.
yes,
Oh, Gleevec, you have to take it for life.
yes.
So there is no end in sight. Nobody does research. Oh, when can we stop Gleevec for CML?
Yes.
Why cannot we stop it after 4 years or after 3 years? We have to keep giving them $5,000, $6,000 a
Yeah.
month.
No question.
So the system is absolutely crooked. That's why honestly I think I kind of have thought about the same thing.
Good.
Because it occurred to me that this is a crooked system.
Yes.
We are standing at the same point that I was standing to 25 years ago when I started.
Thank you for
this thing.
saying this. Yes.
Seriously.
Thank you so much for speaking up. Really appreciate it. You are absolutely right. Hina.
Achi, thank you for being here. I call you Achi as well because I know you
course.
through Zehra. Amir and I met you, I think it was back in 2012 at a dinner in Louisville, Kentucky. And we were immediately smitten. I remember talking to Zehra after that, and I was like, oh my god, I'm in love with your Koki. So, and again, you know, you just continue to impress and so inspired by you always, every time we sit down and chat with you. I'm a geriatrician, so unlike oncologists, meet a lot of the patients nearing the end of their life, and I'm in the business of giving them a good death. And so, you know, experience them at the tail end of their life. So, you know, again, a lot of these stories are also kind of hit home and close to my heart. And so, you know, a lot of things that you speak about, and I've started reading the book and I haven't gotten through it, so I'm very interested to go into the details of how this is going to come about and how we can support you further. But my question is, are you being met with resistance from your other esteemed colleagues in the world of oncology across the US and the world, people who are starting to read your book and listen to your ideas?
What a wonderful
And how
question.
to counter that?
Hina, I love you too. What a wonderful way to start this. I may have met you in Louisville, Kentucky, but I was smitten by you as a dancer. You and Amir did an amazing job dancing at Zehra and Hussein's wedding, and basically beat us into submission. The Razas were shamed into sitting down. But look, this is the funny thing. I'm doing this at the tail end of my career. I have nothing to worry about. What are people going to do to me? This is, as Zehra mentioned, this is my third endowed professorship. I had my first endowed professorship when I was 39, the Charles Arthur Weaver Professorship. Now it's the Chan Soon Chong. And when I was at University of Massachusetts, I was the head of hematology, oncology, and bone marrow transplant, and had a chair, the Gladys Smith Martin chair, that the president himself gave me. So I've been there, done that. I don't need anything anymore. I'm completely fearless and in saying what I'm saying. So I decided, why not start my assault from Columbia University? So I gave grand rounds 3.5 years ago. I started by giving grand rounds at Columbia. By the end of it, Gary Schwartz, who's now the head of the division, came over and said, Azra, you were our scientific leader, but from now on you are also our spiritual leader. He had tears in his eyes. And Ed Gelman, who was the chair before, Ed stood up and said, Azra, before the young people in the room slit their wrists, can you please tell them what is the next step forward? Because basically I gave a scorching, scathing criticism of everything that's being done. Then I went, 3 years ago, I went to the Institute of Human Virology, University of Maryland, and gave a lecture in front of 500 people, Cancer and its Discontents. At the end of the lecture, Bob Gallo, one of the biggest names in the country, got up and he said, can you tell your husband to dial down his... So Bob Gallo stood up at the end of my talk and he said, Azra, I don't know another person in the country who could speak like this. Oh, mainly, not just because I'm one of the few people who has a cutting edge research lab and sees patients, and I'm a cancer widow, but I have 35 years of experience. So it's not easy to come up with the kind of gravitas that I have. He said, it's not enough for you to just give these grand rounds and lectures, you need to speak to Congress. Come back next week, I'm going to introduce you to the president of the board of trustees here, and then we'll take it from there. I said, fine. I went back the next week. I gave a presentation to the president of board of trustees. Now we're talking University of Maryland. From that room, Hina, he made a call to Vice President Biden's office. And they agreed. They said, yes, Dr. Raza should come and speak in front of Congress. And I backed down. I said, look, I'm writing a book. Let me get the book out. I will have a better pulpit to stand on. And then they won't just take me as some chit of a brown female who's standing up and criticizing everybody. There will be everything in writing now. And I have documented, there are 1,000 or so references at the end. I mean, I'm an academic person anyway, so everything is like backed up. You can't make up these statistics, they are so bad. So they said, fine, come back. So how did I begin my assault? Do you know that the Wall Street Journal, which has a bigger circulation than New York Times, put me on the cover of the Sunday magazine? You guys obviously don't read it. So there's a beautiful picture of Harvey. Okay. New York Times has done an amazing review of the book. Wall Street Journal on the cover, New York Times, and yesterday, 2 days ago, in fact, actually I have it upstairs, I'll bring it after we finish. The New York Post has done a huge feature. This oncologist's view is very different. And you know, the Wall Street Journal piece that I wrote, the title is that cancer is still beating us. That's the headline. And all these statistics I said to you guys today, they're all in that one essay that I wrote for the Wall Street Journal. I'm doing 4 to 5 NPR programs every week. Al Jazeera, I don't know how many channels I've been on already. So actually, people are ready to hear this. Look at this oncologist who immediately wanted to even interrupt because he agrees and he is experiencing all the frustration himself. So the public is somehow misled into believing that wonderful things are happening in cancer treatment. There's a misconception, and you know, it's not that we are not seeing the solution in cancer. We are not even looking at the problem clearly right now. And the problem is cancer is a very complicated disease, and no amount of molecular biologists huddling together with their reductionist strategies are going to be able to solve the problem in this lifetime. Because every time a cancer cell divides, it picks up new mutations just because of copying errors of DNA that happen at random. So each time a cell divides, it becomes a new cancer. It is so complicated that to try to replicate that complexity in a mouse model or in a petri dish, that's why we end up with a 95% failure rate, and 5% might as well have failed that are approved. So I'm saying it's like saying I'll cure aging. You might do it, but in a 2,000 more years. You're not doing it anytime soon. So what is the earliest solution we can find then? The only strategy that has worked in cancer is early detection. Why aren't we going there? The only strategy that worked for cardiovascular diseases. So the point is, you asked me, is there going to be a lot of backlash? No. Actually, people are ready to hear it. People are giving me the voice. Everyone is inviting me to speak up, and so far, let's say my piece in Wall Street Journal, you know, the people who write comments, they are insane. Do you know, out of 300 plus comments, there's not a single negative comment? Which is like, I'm shocked. Because even on my good talks like Shahi and Fakiri, Lahore at its best, there are some people who found objection in that talk and started writing madness. Why is she speaking in English? I mean, so people find crazy reasons to, you know, criticize you, but no one is criticizing this so far.
That's wonderful.
But finding cancer early not always cures it. You've been working on myelodysplasia, it hasn't been cured yet. So just by finding early, not always, especially myeloid malignancies.
Yeah.
So, I mean, it could be different
I'd like
for
to
breast
answer
cancer
that. No, no.
and solid tumors.
Yeah.
But I think for liquid tumors, it may be, finding early may not be
Yes.
enough.
First, I'd like you to know that for 35 years of my life, I have done nothing but think about this. So there's nothing new you or anyone is going to tell me. So don't think that you're suddenly going to find me out and tell me, oh, Dr. Raza, you are wrong. You can't cure it. I want to just right away tell everybody that do not think that I'm somebody who is so thoughtless, I haven't thought about any of these things that are occurring to you like this, somebody who doesn't see MDS or leukemia even twice a year. So the answer to your question is, of course we are not going to be able to cure every cancer, but we don't, you see, you keep thinking about MDS as it is today when the whole body is taken up with it, and you are saying, oh, you haven't cured them. Yes, because it is a malignancy by itself and it's already too late. So you need to think a little more deeply about this before speaking, because think of what you said. MDS is not just a pre-leukemia. It also kills by itself. 2/3 of patients with MDS die of MDS.
It's a neoplasm.
Yes, it's a neoplasm and it's all over the body. So that's too late. This is why the point is that who are the people who are getting MDS? We have to start screening them at health and appearance of the first few cells. But then how are we going to kill the first few cells? Not with chemotherapy, not with radiation therapy. That is why the biomarker study is so important. We need to find specific targets that can then be loaded onto T cells. Now, CAR T therapy is so toxic right now because you have to kill billions of cells. But if you have to kill a few million or a few 100,000, it won't be like this. So with technology, the development will be in detection and elimination also. Not, you are imagining that we'll detect the first cell with the latest technology, but then treat them with these Stone Age techniques. Of course not. Okay. Yes, Noreen. Noreen.
Dr. Raza, thank you very much for your great hosting. An honor that you're a Pakistani and done such a wonderful job. Going back to the thing you mentioned about the bra, right? I don't know if I'm wrong, please correct me. Why they denied the mass production of that bra? What I remembered, if I'm wrong, please correct me.
Yeah.
That it was mostly the oncologist who were against that because the logic was that it's going to be overdiagnosed. We are giving a tool to the public who doesn't understand how these markers work, and it's just going to create anxiety in the general population.
Yes. Good question, Noreen. The first, in the beginning, there may have been some pushback, but the big trial is going on right now, actually, for the Smart Bra at the Canary Center at Stanford. So we are very hopeful that it will come through. And yes, there is a certain level of anxiety associated with knowing that I'm at high risk of getting some cancer, but that's exactly what I'm telling Akhtar here, that no, it won't be just that you are being diagnosed as having high risk early or finding it, but we'll have means to treat it simultaneously. So every new solution will come with its own set of problems. I'm not going to sit here and say we have solved all the problems. No, all I am saying is, look, the current strategies are not working. We have to try something different. We have to stop hurting patients. And like Akhtar keeps saying over and over, that we are just feeding a beast in the pharmaceutical industry. We have to stop doing that, stop ruining our patients physically and financially, stop following this losing strategy, try something different. Now, it will come with all of these problems, we have to address them. Bill.
You might have to come a little closer. Sorry, this thing doesn't.
Okay, I actually have two short questions. Oh, okay. If by some chance the Secretary of Health and Human Services appoints you to realign the priorities in cancer research, what would be your primary emphasis and what is being done wrong today?
Love that question first.
Okay, after that I'll ask
Okay.
you another one.
This is a brilliant question, Salman. So I'm doing something called the Cancer Questions Project right now. And I came up with 5 questions. One thing you guys may not know is my Rolodex is very good. Because first of all, I was married to Harvey Preisler, who knew everybody. And he was the head of the Cancer Center from a very young age. So I have been associated with the leadership in this country for the last 30 years. So I know a lot of very, very smart people who are in leadership positions. So what I'm doing is I came up with 5 questions. I call them the cancer questions, and one of them is exactly this. If you had all the resources in the world, what is your solution to curing cancer tomorrow? And everybody's answer is more research, which is perfect. Of course, you can't cut corners in science. Look, I have a very active research lab, and you just can't shortchange that. You have to go through the rigors of a scientific inquiry. And that's the only way to move things forward. I agree with Akhtar here completely, in that we are always faced with 2 issues. We have patients now, and we have future patients to worry about. What should we do for patients now? First thing we have to do for patients now is to stop hurting them, what I have been saying all along. We have to stop giving them useless therapy, stop and be very honest with them. Take away our blinders, face the reality ourselves, and not push these kinds of drugs on patients even. Talk to them honestly. These are your chances. Your chances are 80% chance you will only suffer all the physical toxicity, you will be financially ruined, your next generation will be ruined. Do you want to take this chance? But if you are one of the lucky 30%, then you will live 2 months longer. Maybe they'll decide differently, although a lot of people still don't. They still don't, because they'll say, even if there's 1 in a million chance, doc, give it to me. But at least so my question is, why are we even offering these things? Exactly what you said, because we have handed over the decision power to authorities that then grant these drug companies, and the decision-making agencies are under the pressure of advocacy groups from patients who are saying, oh, how come you don't have new drugs? So the institutions feel like they have to get more and more drugs approved, so they can say 72 new drugs approved for cancer this last year. But what are these 72 drugs doing? Those are the details I've given. So when you ask me if I had all the money in the world, what will I do? First, stop hurting the current patients, be very honest. For the future of oncology, this is what I spent the whole last hour describing. We need to try to bring the latest technology to the bedside. I don't know what it will show, what new treatments will appear. For example, one of my friends, Sam Gambhir, who heads the Canary Center at Stanford, he calls it, okay, cancer when it's just beginning doesn't easily give up its markers, so you can yell at it. How do you yell at a cancer? You strike it with sound waves, that's yelling. Then it yells back at you. When sound waves hit the cancer cell, it will shake off some of its protein. You detect them in the blood through a liquid biopsy. So these are the kinds of new technology, these implantable devices, these scanning things that are all coming now, are in different stages of development. I would support 50% research for current treatment, 50% research for early detection and prevention.
Can I ask another question?
Please, I just have a comment.
I'm sure some of you are familiar with the concept of balanced polymorphism.
Yes.
People with sickle cell anemia suffer the anemia, of course, but they are resistant to malaria.
Malaria, yes.
And if one puts on evolutionary blinders and looks at the rampant increase in the number of cancers that have occurred in this century, firstly, do you think that this occurred all along? And secondly, do you think there is some evolutionary advantage in thinning the gene pool and eliminating harmful genes?
Excellent question. In fact, I have a long chapter on evolution here, because I agree that a lot of people ignore it. But I have to correct one of your statistics. It's not true that incidence is increasing as in general. It's only more cancers are being diagnosed because we are living longer. Cancer is a disease of the elderly. As the population ages, more and more people are getting cancer. So prostate cancer, more and more people. Plus early detection increases the number. Because we are
Not that, but
diagnosing,
you're older
yes,
now.
yeah. So it's not, the incidence isn't increasing as such, and it's not as if we are exposed to more toxic things or that cancer has some advantage for something else evolutionary wise, and that's why we are developing cancer. No, it's not that. Yes, Nori.
So going back, making your priorities, what about kind of doing some research on looking into antecedents of the cancers, before even prevention, what is why we're getting all these mutations, what the environmental factors. So like you just gave an example of cardiologists, they're kind of preventing smoking, for example. So why not we spend some money in that area too?
Because frankly, they are so vague, except for smoking and some lifestyle changes. You can lead the most pristine life with great exercising schedules and great eating habits and live in the healthiest atmosphere and still get cancer. Because cancer is a random event also. That with time, every cell ages. You are going to die. And death is going to come because of old age, and what we are trying to do is live to that age in a healthy way and then die. So how does cancer arise and why do mutations arise? It's a random event. Every time your DNA is copied, it makes 3 to 4 random errors per division, 3 to 4. So there is something called a Hayflick limit, which means that a normal cell can only divide up to 43 to 46 times, and then it cannot divide anymore. But a cancer cell overcomes that Hayflick limit and becomes immortalized and keeps dividing. So each time the cancer cell, which is supposed to take 2 weeks to divide, is now dividing every 24 hours. It picks up more and more and more mutations all the time. But how did it begin? It's a random thing. That's why it doesn't happen to more people. Cancer is still very rare.
I can see. Thank you, Dr. Raza, for speaking. I wanted to speak to the issue of corruption of medicine by pharmaceutical industry and how that actually kind of trickles down to the fellow level of education of young oncologists. I mean, sort of the hidden curriculum as I've seen it is that, to be a good oncologist, you have to subject the patient to 3, 4, 5 lines of therapy before giving up, otherwise you're not aggressive enough. And we've learned that the NCCN guidelines, which might as well be handed down as, tablets from Moses, are written by people who are in bed with pharmaceutical industry. They have a lot of ties to the pharmaceutical industry, and probably the people who write our questions for the ABIM are probably similarly conflicted. So we're answering the question, which of the one is the best answer. The patient wants to proceed to next therapy, and very rarely do I see these questions saying, it's time to focus on comfort. So speak to that.
What a beautiful, Bill, I'm not that cynical. I think that NCCN leaders mean well, and they are trying to review everything that's available and then come up with some guidelines that at least there's some uniformity in what we do, and instead of randomness completely. But to answer, I'd like to ask you a question. If you go to the corner drugstore today and want to buy 100 Band-Aids, you can get that packet for $3.99. But if we put a Band-Aid on you in one of the hospitals, it will cost $75. What pharmaceutical industry is involved in that? It's the hospital that's so corrupt then. When I came to this country, hospitals were run by doctors. Today they're run by businesses. So why do we keep blaming pharma industry? I'm glad that you brought up that all of leadership is corrupt in oncology. Everyone, one of my friends calls it paycheck oncology. Everyone is basic scientists. Imagine the insanity of this now. Basic scientists are studying a disease they never see in animals who don't get it. This is what cancer research is. What PhD sees cancer patients? How many PhDs have sat there and documented night sweats like Harvey had in a mouse. How are you studying a disease that you've never seen? In animals, you create something in them, you put some cells, immunocompromise them by killing their immune system, then grow some cells, then treat it with a drug and say, aha, let's take this to the bedside. This is all, we can't just keep blaming the pharma industry. We are all in it, oncologists, professors, doctors, academicians. I blame myself all the time also. Why am I doing this to people? You imagine for 1 second that I have been having the same conversation with AML patients since 1977, describing the same side effects of 7 and 3, what are their chances, what's going to happen. For 40 plus years, I'm doing this. It's shameful. And I blame all of us. We all have to change as a society, we have to change, because the present situation is untenable. Even financially we can't afford, the system is becoming corrupt, completely ruined. So, yes.
I mean, it's, you know, you are absolutely right. You have to be always a visionary. You know, you always see, you know, behind what we do, right? We are so focused in everyday life and patient to treat and, you know, whatever. But, you know, it's a lot. I mean, where to start? I mean, you have to change the mentality of the providers, because we are not physicians anymore, right? Providers. You have to change the government, because it has a huge responsibility. You know, in other models that are not capitalistic, you know, things maybe work as well as here. Survivals are exactly the same. Why is that? Because they don't have that much money, but, you know, people live the same, right? So I'm just saying it's different levels. I mean, it's political, it's the culture of the physician, of the medical, you know, community, and it's the pharmaceutical. I mean, it's a huge thing.
No, but I can tell you how to change it overnight. That's the answer I give in the book. Don't be intimidated, because think about it. If you were going to keep tinkering with the typewriter, you would never invent the word processor. Who wants to use the typewriter today when the word processor came out? Overnight things changed. So, one of my favorite books, which I recommend to everybody, which I read every 2-3 years, is The Structure of Scientific Revolution by Thomas Kuhn. Kuhn proposes how paradigms shift. They happen overnight because too much insanity builds until it just system breaks. We have been reaching that boiling point now, and the system has to shift. And so my point is that once we have a new goal and we show a better way, nobody will want to use chemotherapy, radiation therapy, or do trials which have a 95% chance of failure. They're not crazy, they'll go for the winner. So it's our responsibility to show a better way. This is what I'm asking for, is you can shift the system overnight if nobody will willingly give up what they're doing, including the mouse researcher. I mean, everyone misquotes me about animal research. I'm not saying that all animal research is useless. In fact, animal research is the best thing as a biologic tool. We need it. The only thing I'm against is you can't treat a mouse or a rabbit with a drug and then say, oh, it will work in humans. So I'm only against animal models for drug development, nothing else. But mouse researchers start sending me hate mails immediately when they read, oh, I'm against mouse models. I'm not against mouse models for biologic research. I'm against mouse models for drug development. In fact, yesterday at Harvard, I was saying that Norbert Wiener stood here and said, in 1940, he said, Zehra, the best model for a cat is another cat, preferably the same one. That's how good a model has to be, that even we can't take 100 patients with pancreatic cancer and say this drug worked in so and so, so it will work in 99 others. No. because the second person's exposome may be different, their metabolism may be different, so many reasons why they won't respond the same way. So I'm not that pessimistic. I'm not going to be discouraged by thinking, oh, these are insurmountable obstacles, because I'm also old enough to know that once a new thing comes, everyone forgets about the old. Once PCR came, who's doing northern blots anymore? No, really, I mean, we just switch immediately. Now that CRISPR is here, my lab was the first to establish CRISPR in in all of New York City. We CRISPR genes in and out all the time. No one even thinks anymore. It's like the molecular scissors 10 years ago, it was like, oh my God, how are we? Nothing, switches like that. So I'm not at all concerned. You should all be very hopeful, in fact. We just have to shift the resources a little more towards the right strategies.
So I think it is happening, Dr. Raza, and I think
Yes.
we should not be that pessimistic.
Yes.
So I teach academic medicine, inpatient medicine, and the big concept that we have now is high-value care, which is what can we do to the patient, which provides the best value for their treatment, whatever the case might be. And the discussions and the arguments that we've had, that we spend so much money per capita every year and our outcomes still are the worst compared to the developed countries, has taken steam. And so a lot of inpatient medicine now is geared towards high-value care. Yeah. And that's what we're teaching our residents.
Excellent.
As well. So it is happening. I think with pioneers like you, with enough discussions out in the open that we need to rethink our strategy, I think the paradigm shift will happen.
Yes.
It takes time, but I think there's enough young minds out there who are talking about it where it is happening. So
Thank you for that positive comment. I couldn't agree more, really. Sabrina?
One quick thing when we're talking of, I was listening and thinking a lot, and thank you so much for so many ideas. I'll see you tomorrow.
Hi, Emma. Thanks so much, Mama.
Is when we're thinking about all these new things, one of the things we see, every day is how the inequities of care. And when we're thinking about something new that's very expensive to develop, and it's going to be very expensive initially, how do we get that level of care to the people who have less resources? And how do we bring
I don't know.
this?
That's something I really don't know.
Because I feel like prevention and I feel like screening, there's huge swaths of our society who are under-screened and who don't get as much of the preventive medicine that we have.
Look, I mean, it's very clear, I can speak for cancer, that cancer incidence is much higher in areas in the country where healthcare is not efficient and where lifestyle is terrible. There's a lot of smoking, a lot of drinking, a lot of unhealthy eating, and those are the places which are socio-economically challenged with little healthcare options, little preventive measures, little lifestyle education that have a higher incidence of cancer of certain types. So there's no question about the inequality, and in fact the NIH has started All of Us trial. It's called All of Us. And the trial is supposed to recruit 1 million normal, healthy individuals, but 80% of them from challenged backgrounds and from non-white backgrounds, so that we get some idea about the non-Caucasian part of the country also. It has already accrued over 250,000 individuals in it, and they are looking at environment, at biology, at diet, at geosocial backgrounds, etc. And all these big data clouds are being created so that some of these people will develop schizophrenia, some will develop multiple sclerosis, some will develop cancer. What were the things that led up to it? Everyone's blood is being saved and samples are being saved, so we can look for analytes and metabolites and biomarkers, that who were the people who developed multiple sclerosis, what were the first steps 10 years ago on them. So there are things being done. things of this nature. In fact, the director of the NIH, Francis Collins, wrote a beautiful piece, his vision of the healthcare in America, on 24th October last Thursday, which came out in Time magazine. I recommend it to all of you. Time magazine has a special edition this week on medical advances. And Francis Collins describes his vision, and he describes this all of us trial in great detail. In fact, I've written to Collins after that and proposed that he read my book.
So I think if we're breaking up the pie, that has to be
Very important.
part of it along with
Yes.
when we frame shift a little bit, to put that at the beginning as well.
Yeah.
Certainly where I practice, I see that every day.
I think.
Can I please end with a share?
Yeah, please.
Then we'll talk.
Okay.
So,
I just wanted to recommend to Sabrina.
okay, here.
I think Sabrina, and I think you worked in a memorial.
Yes.
So you know that
Yes,
we have to work at the psyche of this low socioeconomic population too, because they don't believe in prevention and they can't afford. And yeah, and a second, on the other end of the spectrum is the people who can afford the best quality care. So this is a true story. Ahmera told me, an 84-year-old woman diagnosed with stage 4 some cancer. So she talked, everything, nothing has to be done. Son flies, who's a lawyer in Miami, was not seen the mother in 10 years. Oh no, doctor, I want everything for my mother. So we have to I think we have to work on the psyche and education needs for that prevention and everything also. Because I see the both ends.
Well, sometimes when I'm giving someone the option of a treatment that may extend their life by a very small amount, it's very hard for me to realize the amount of money that I spend for that. And that's my patient. And we talk about the pros and the cons, financial, social, emotional, as well as the side effects of the drugs, and talk about those benefits. But then I also say, in that moment, I have to advocate for the patient. When I leave the room, I sometimes think about the amount of money that I've spent there in terms of my time and in terms of the drug. And is there a way for us to use that to prevent with the tools that we have now? But thinking also then, if we have tools in the future, if we're thinking we need better prevention, better diagnosis,
Sabrina,
how do we get that from the beginning across the strata of society?
Sometimes what I've seen, if you explain it well, patient choose the right thing.
Oh,
Like
I've
I
seen
just
that
was
too.
having
Absolutely.
a discussion yesterday.
Absolutely.
This lady, very elderly lady, 80-some years old, she has a now small lymphocytic lymphoma, quite extensive, she want to treat her. So I said, well, there is this ibrutinib you have to take every day, and then you have this chemoimmunotherapy, you can do a short burst of treatment. And you know what she chose? She said, I don't want to take all the rest of my life. I want to have chemotherapy. And with the chemoimmunotherapy. And I would say, that's a right choice. And I didn't tell her, just take this ibrutinib. But she said, no, I'm going to have for 4 months this treatment, and I will read the rest of my life without treatment. So I'm saying,
okay, can we just have this conversation in private, because we don't want to keep everybody here. This is an endless discussion.
Yes.
So I'm really I'll have to put a stop to it. Zehra is too polite. So I want to give Zehra the chance to thank everybody. I thank everyone very much. And I'll end with one sher, which is, I'm sorry for non-Urdu speakers, I'll translate it, but और सब भूल गए हर्फ सदाकत लिखना, रह गया काम हमारा ही बगावत लिखना. Everyone else has forgotten how to write the truth, but we still know the language of rebellion.
Thank you so much, Ishti. Thank you, everyone. Thanks for coming and for your wonderful questions.
Thank you, Zehra.